I hope that you can hear my voice clear and loud. So welcome to the session where I'll be happy to have friends and colleagues here to help me describing, explaining, discussing, chatting with you about something that is absolutely hot topic now. And definitely, well, the title is ambitious, as you can see, because we will talking about pushing the boundaries to optimize patient outcomes from planning to success. Of course, you will immediately understand that we are talking about the acute results as well as the considerations that we must do in 2024 to ensure a long-lasting results. Okay? So, very close to me will be Professor De Backer that will help me dealing with this 1 hour session. And let's, for the sake of time, just move on and talk about the objectives. To know more about the factors that determine the best possible TAVI outcomes in a variety of anatomical situations. Of course, we will discuss about different anatomies, different patients, different clinical scenarios, and please be interactive as much as you want. Don't feel shy, just ask questions. We'll try our best to fulfill all your needs. We'll also try to understand how a tailored approach can help to address the lifetime management for individual patients. Because of course, the key thing is to try as much as possible to tailor the procedure on the actual patient. But also we'll try to acquire useful tips and tricks, and I will take advantage of all these guys, all the experience they have, and I actually force you to do the same. Just take advantage of the high experience that you have now to understand from high volume experienced operators. So let's just, these are my conflicts, of course. I would like to start from just a simple but relatively, let's say, common case. This is, as you can see here, a relatively small anatomy. And we all know that in 2024, a small anatomy, as a matter of fact, is still a concern because we don't really know what is the best option for this patient. Let's say that this patient is relatively low risk, is a relatively young patient with small anatomy. So the question is, in 2024, what is the consideration you have to take into account before planning the procedure, but also what are the limitations of the other possibilities? Someone can also argue that this is a good indication for, let's say, a surgical approach maybe, because it's low risk, or maybe just something like the annulus plasty to enlarge the anatomy. All this consideration will be done. But also, if you look at that, this is truly small anatomy. We wanted to start from here because this is one of the real pending questions we need to answer. The localization of the main source of complications is still, in 2024, the femoral axis. So it's absolutely crucial that we know the anatomy, we know how to do it, and we know the toolkit that we need to have in our lab in order to make sure that we minimize all the possible complications. And we'll talk about it. So, please, Ole, I give the word to you.
Yes, thank you, Luca. So, this is now a fictive patient, young patient, low risk, small annulus. So, I think it's important that if we start to treat these patients with a longer life expectancy, yes, that's what we're talking about, what do we have to think of? What do we have to consider? And I think if you look to TAVI, well, the first TAVI ever was done 21 years ago. As by Alain Cribier, as most of you know. So there's kind of 20 years of experience, or at least for sure the last 10 years, a good experience in TAVI. And we have been focusing mostly on optimizing the acute outcomes of our procedure. Yes, I think we have all become pretty good in that, in increasing the procedural success, making that the patient, at least without any complication, comes out of the lab. Vascular closure management, most of us master this. Paravalvular leak, that we reduce it, keep it as low as possible. Optimizing, thinking of valve hemodynamics. I think we have that reflex already with many operators. Also improving our implantation techniques to reduce pacemakers. I think that's what we've been focusing on the last 10, 15 to 20 years. Yes? But if we discuss a younger patient with a longer life expectancy, there are a couple of other aspects which become suddenly important. For example, coronary access becomes increasingly important if you treat a younger patient or at least a patient with a longer life expectancy. Commissural alignment becomes important, especially valve durability. Ideally, you want to give your patient one single valve for the rest of his lifespan. Valve thrombosis or valve thrombosis or leaflet thickening can be an issue also. And then also the options for redo-TAVI. That's something we have to think of. If we treat, for sure, it's kind of a reflex for me. If I think it's a patient with an estimated life expectancy of more than 10 years, I try to think of what valve goes in as my index TAVI. Yes, this is something not to neglect. So these are just a couple of aspects I hope we come to touch on in the next 55 minutes of this presentation. So Tiffany, I want to hand over the word to you first, because going back to the case of Luca, this was a small annulus patient. So which considerations do you have on this particular patient regarding that?
Thank you. Thanks. So I've just got a couple of slides I'm going to show. So the issue with small annuli, or one of the major issues, is that you risk patient prosthesis mismatch. So the valve potentially is not the right size for the patient, and that's associated with increased mortality. And we've learned that from the surgical data, and this is just a small slide on the left-hand side showing a meta-analysis of surgical data, but really these patients don't do well. So they have increased mortality, their valve degenerates earlier. And in TAVI, it's not as low prevalence or incidence as we think. You know, this is happening in TAVI. Obviously, the surgery, it's higher risk of PPM, but it does happen in TAVI, and it is a real risk. The other issue that we should probably touch on is the cohort of patients with small annuli. About 80% of them tend to be females. And actually, if you use a cutoff of 430 or 450 even, people are now bouncing around that number, then it's basically 35 to 40% of our population. And it may be more of the population in Southern Europe and Southeast Asia. Interestingly, you know, there's good data now. This is just one registry insights, but we can get very good effective orifice areas from self-expanding valves, and this matches the hemodynamics as well. And you can see the PPM risk, severe PPM risk, is actually very low relative to the early TAVI data here, and you can see that on the right-hand side. And it really, the valve size, 23, 25, 27, 29. 29 is 0%, but the rates are still super low, even with a 23 millimeter valve. And I guess that leads nicely on to hemodynamics and the importance of hemodynamics.
Yeah, for sure, and thank you for this. I just want to stress one little point. I mean, obviously, the presence of the gradients has been associated over the surgical experience to one single problem, which is the faster degeneration. Of course, it's not just that, but definitely one of the main components in the consideration of lifetime management is to try at least to anticipate what is going to happen. And obviously, when you have a small annulus, you need to consider the different options. And it's all around the anatomy, of course, that you cannot really change, but definitely you can do something in terms of selection of the appropriate prosthesis, but definitely the hemodynamics makes a lot of difference.
Those different goals, like regarding hemodynamics, we want to have them excellent. That means good integrate hemodynamics, low gradient, not to have any mismatch. I fully agree with all those comments. And of course, we don't want to have a negative retrograde hemodynamics, meaning no paravalvular leak. We want to have preserved coronaries for longevity. We want to have good rhythm. We want to have good long-term function. And for that, I believe CT assessment and good planning is paramount. It's very, very important to select according to the type of calcification to specifically analyze it. Most of us will use the Tremendous software. There are others around to plan for the ideal valve size and valve type. And this is very important for a good long-term hemodynamic function of the patient. Paravalvular leak, shown on the right of this slide, has negative impact upon outcomes and should really be avoided. We know everything more than a mild leak leads to impaired survival of our patients, which we don't want. And maybe one tool to obtain ideal hemodynamics in long term is some automatic support and artificial intelligence-based CT analysis. We've performed an initial trial in our center on a fully automatic CT analysis. My colleague, Dr. Arslan, presented that at the ESC this summer. That's the left poster shown there. And this is a potential further tool to predict and optimize outcomes and thus help us with valve selection. Not everyone is so experienced to do TAVI for 20 years, as shown on the initial slide. And actually, I'm one of the guys who had the opportunity to start 20 years ago. But such a tool, I still believe right now, helps us all to improve the size selection and the valve type selection for optimal longevity of our prosthesis. Thank you.
Well, actually, I really totally agree. And as a matter of fact, we all know that planning is the key for success. But now I just want to ask a question to Ole. What do you think about this? I mean, obviously, the selection of the type of prosthesis makes a lot of difference. So can we say in 2024 that at least we need to decide whether we are going to use a self-expanding valves or a balloon expander valves for this kind of procedure? What do you think?
Well, I want to bounce that question maybe to Thomas. I mean, up till now, the common belief in the TAVI community is more about hemodynamics. It's thanks to a supraannular leaflet position, we get better hemodynamics. What's your take on that? Is that the determining factor? Is it multifactorial? Which factors determine that you have a better hemodynamics with one or the other valve? And what then specifically about, for example, Navitor? This is intraannular leaflet position. What about this valve? How does it perform also with hemodynamics?
Actually, when I think about the whole complex, it's always a big package in total. Like I think mostly on the calcification, we have two types. The elderly patient with a tricuspid, even distributed calcification. We have the younger patients we are thinking about treating them with TAVI, who have more or less a bicuspid anatomy, be it type 0, type 1, according to Sivas. No matter. This doesn't matter, but in the end, bicuspid is different. And for those who have an other valve in mind, probably, than for those who have a nice tricuspid. There are these patients where any valve will work. And these valves will then have a good integrated hemodynamics. In the narrower annulus, I would go for a supraannular valve in comparison to an interannular. For many patients, it really wouldn't matter too much.
But is that really the thing? I mean, is it really thanks to the supraannular leaflet position that you get better hemodynamics? I'm not sure about whether that is the determining factor. Apparently, if we look to the data out there, as also shown by Tiffany and the small annuli, with Navitor 23-25, you get optimal hemodynamics with almost no ppm, severe ppm. So there must be other factors which determine this, maybe more how these leaflets really can maximally open, coaptation, etc. That's maybe more determining factors.
Yeah, well, as a matter of fact, we got some hints from the literature we can take. For example, in the previous generation, we know that at 5 years follow-up of the first Portico IED trial, they showed clearly that the gradients and effective orifice area was actually totally overlapping with a supraannular prosthesis and platform. So, in other words, I mean, we need to consider, of course, in order to tailor the procedure, that what we know about the hemodynamics, but also what we know in terms of leaflet, in terms of supraannular or infraannular physiology is a lot, but still it's not the whole scenario. We need to consider what we are doing. So honestly, my feeling is that it doesn't really make a lot of difference for the regular case, but definitely, as we were discussing before, having different options is something that we need in 2024. So, in other words, again, planning, again, knowing your tool, knowing your platform, knowing your device. But is it really something that we can do all the time here? Maybe, but depending on the availability, depending on the expertise, depending on the tool set. So it's a thing that we need all to consider. So this is really, really important. So I would like to move on to the next. So,
You don't know.
okay. We all know that in terms of durability, the turbulent flow, the geometry of the leaflets, all the engineering stuff that has been done so far makes a lot of difference. And durability is one of the key factors, especially for the long-term evaluation of what we are doing. Because clearly, as Ole pointed out before, ideally we would like to place one valve there that will last forever. But we all know that especially if we are dealing with a young patient, low-risk patient, we need to consider that one day, this bioprosthesis, because this is what we are talking about, we may possibly fail. So we need to really look at durability carefully. So please.
Yeah, valve durability always plays a role in the discussion on how to treat the patient. There's ongoing rumors that the TAVR devices may not fare that well like the surgical devices. And actually, there is some truth in it because we did not have data for many years due to the fact that the initial patients we treated were very old. So the valve did not have the chance to really show how good it works over a period of, let's say, 10, 12, 15 years. But in the meanwhile, this changed a little bit, and I brought some data here from the NOTION trial, and you can see here randomized 140 patients per group. And if you have a look on the upper panel here, you can see that the curves are absolutely parallel. So there is no difference whatsoever between the surgical valve and the TAVI device, which is really promising. And perhaps even more important is if we look a little bit deeper here on this panel here, you can see the structural valve deterioration. And if there is a difference, and statistically there is a difference, it's in favor of the TAVI device, not in favor for the surgical device. And this may perhaps be due to the better hemodynamic of, in this case, a very supraannular device in comparison to the surgical device. We just discussed that hemodynamics may play a role, and therefore I brought some data from the Portico device, which derive from 3 large trials or registries, and you can see on the left side more than 1,500 patients have been included. And this is not like 10 years so far, but at least it's 5 years. And if you see on the upper right panel, the hemodynamics are excellent. Here you can see the effective orifice area around 1.9 centimeters squared and absolutely stable over the whole period of 5 years. Same holds true for the gradient. Really good gradient, around 7 millimeters, even below 7 millimeters of mercury, and again, absolutely stable over 5 years. And this is somehow promising, and then there is no good reason why this should change at 6 years, 7 years, or 8 years if you have such a really stable situation. And if we go further, we have a one more important point, namely that this holds true more or less for all valves. Even the small valves, and we just discussed it before, you could expect that there are some problems, but this is not the case. As you can see here, the gradients on the upper panel again, blue and red for the smaller or the larger one are absolutely equal. And again, even for the smaller valves, there is no tendency whatsoever for an early degeneration. Therefore, the valve durability, I would not claim that it is solved, but it's really a good result, what we can see here, and we can really rely on the devices which are available today.
So maybe, Helge, do we have surgeons in the room here? There must be, yes?
Do we?
Yes. What I want to hear a little bit, what's your take on how do you look to durability, TAVI devices versus surgical valves? How do you think about this topic if you're dealing with a younger patient? Let's say you have a 70-year-old patient in front of you. How do you think of these durability issues?
I think it depends on the age. You know, if we limit it to 70 and above, I think the TAVI valves will, perform well, and then they're going to more or less equitable. I think we're coming in the younger age group, especially the small annuli and all these, and I think in this group of patients, we need to think subsequent procedures. And I think ideally these patients should be managed in a center where they can have good experience with valve root enlargement and all the techniques that they can at their disposal. It shouldn't be left to a surgeon who does it once a year, because they're not going to have good results. Because I think especially the TAVI valves, if you plant the valve at annular level, and if that deteriorates and you can't put valve-in-valve TAVI, redoing these procedures is going to be root replacement in these young patients. So they need to be warned about it in advance, that if this valve fails and you require it to be explanted as a TAVI valve, then your risks will be high for the second operation.
Okay, so your communication is, look, durability is important, but be prepared for redo too. I mean, think of if there was another surgeon here, yes?
Yeah.
We have it.
Yeah, but in the audience. Wasn't there? No, okay, so what's your take
comment.
on this?
in those trials, Notion, it's really incredibly good data for the TAVI valves versus surgery, but surgeons are not always doing a good job. We in a surgical field started to use annular enlargement more frequently to avoid mismatch, etc., as we had said previously, and we didn't do that in the past, and not in those trials. And that leads to inferior results of the surgical valves, worse than they could be.
But I'm still sure that if you would do here a poll in this audience, who has in his center, which surgeons do offer really annular enlargement, root enlargement, I'm not sure it will be very high. Yes, but anyway, I think we move on. And indeed, as we talked about redo options, I think it's indeed important. Before I talk about that, I go still on coronary access too, but then it leads to also the redo-TAVI options. And indeed, that's super important if you treat younger patients. But first about coronary access. If you think about coronary access and comparing the different platforms, what are important aspects? Well, first of all, we have a short frame or tall frame. That's a clear difference between some platforms. Then supraannular leaflet position or intraannular leaflet position, also clearly difference. And then very importantly, also if you have a tall frame especially, how dense is the nitinol network, yes, to get through with the coronary catheter. So these are three aspects. A fourth aspect, which is not appreciated very often, is you can put these valves on your table in front of you and compare them, but in a way you should see them as they are implanted in the anatomy. Yes, and not all valves are equally implanted, yes, at equal depths or heights. So here on this slide, I try to give you a comparison of 4 regularly used platforms. And what I indicate here in dark red is the absolute impenetrable. It's not penetrable with catheters. The zone which is absolutely not penetrable, the lighter red zone is kind of more the challenging zone. And then I would like to attract your attention there to the fact that indeed the Navitor platform, it has nice intraannular leaflets, it has very large open cells, so the impenetrable zone is extremely low. Yes, you implant this valve typically around 3 to 5 millimeter, so you see that it's actually extremely low zone where it's completely no access, and then you have these large diamonds. So for coronary access, in absolutely the majority of cases, this is a rather easy way to come into the coronaries. Yes, so that's a good thing. Secondly, redo-TAVI, as our surgeon pointed out, important. So also to give you an idea, what are redo-TAVI options? Yes, and very often, now I would say, how I look at it, if you have to revalve a low frame, you can do sapien and sapien. You can also do perfectly also a tall frame in a short frame. That's perfect combinations. To revalve maybe taller frame valves, I would say I kind of have a small preference for balloon expandable maybe, because then you can adjust your neo skirt by adjusting the depth of and the height of your sapien implant, for example, or balloon expandable implant. So here again, I want to point out to the fact that if you have to revalve, for example, a Navitor, you can do this pretty low. You don't have to go high, so you don't make your neo skirt, your functional neo skirt, you can keep it relatively low. And you still have these large cells. So still, for coronary access, and not only access, but also coronary occlusion risk, it's much lower than other platforms. There is data that's going to be published soon where it's compared with other platforms, and it actually comes out as the best option in comparison to other platforms. And also, if you go for high balloon expandable, for example, in most of the scenarios, that's also going to be published soon, in most of the patients, you will still have the option for revalving of these patients, not bringing them in danger of coronary occlusion. So these are the redo-TAVI options you have, and that you have to take in mind if you treat a younger patient. So I think we come with this topic to Miriam, because you are going to show us a couple of combinations of redo-TAVIs in the bench test. Yes?
Of course. Thank you.
Well, I think this is really a good transition, because one of the big topics now is really what to do next, right?
Yeah.
Because we started from, okay, that's a regular case, what we do, I mean, questionable, debatable approach, okay. But as a matter of fact, well, with the success of TAVR procedure, one day we will see a lot of this kind of problems, and definitely we need to try at least to understand better, in better details, the options, and also what is the beauty of having large cells with a 22 French diameter. So in other words, an easy re-access, because ultimately our problem, our nightmare, is to place a brilliant second TAVI in a TAVI, but the coronaries needs to be protected somehow. So please show us the options.
Yeah, so I think it's a key point that you raised. One of the things when we think about redo-TAVI, the easiest comparison is to say, look, a redo-TAVI is like a surgical valve-in-valve TAVI, like a TAV-in-SAV TAVI, but no, it's not the same. TAV-in-SAV, we have a lot of experience with that. It's pretty consistent, the neoskirt height, and I'm going to show you differences. Redo-TAVI is a kind of mosaic because you have plenty of different valve designs, valve size, valve combination, which are not going to give you the same result. So there are 4 key considerations. The first one is, maybe the most important one, is the neoskirt. So you see that Ole explained that. It's an uncrossable tube graft, which is formed by the pinned leaflet of the degenerated valve, by the redo-TAVI valve. So if you do a tall-in-tall, you'll have the maximum neoskirt height. If you do a short-in-tall, you can manage this neoskirt to be less high than the maximum. The trade-off of decreasing the neoskirt by implanting a short frame valve in a tall frame valve is that you're going to have not all the degenerated leaflet pinned, so you'll have a small proportion, or maybe even more, it depends the way you implant your short frame valve, of these leaflets hanging over the new valve. So this is what we call a leaflet overhang, and you see an example here. You have excessive tissue here from the degenerated valve bending over the first valve. And this may have an impact on valve durability, valve function. We are still not sure about that, but probably the initial mechanism of failure will have a role in that. If it's stenotic, very calcified, you may not want to have leaflet overhang. If it's pure regurgitant mechanism with non-calcified failure, then maybe it matters less to have leaflet overhang. The third consideration, I would say, is valve expansion of both the index valve. If you put a valve inside a balloon expandable in a self-expandable or a balloon in a balloon, you will increase the size of the initial valve. And you have to consider this, especially if you have a risk of coronary obstruction. The second valve expansion is also really important because you see in this example that you have a valve which is underexpanded, the redo valve is fairly underexpanded, and then the leaflet cannot function properly, and this is what we call leaflet pinwheeling. You have excessive tissue when the leaflet are closing, you don't have a proper closing of these leaflets. And I would say that the fourth consideration is commissure alignment. So you want a surgeon do that for all their surgery. When they put a surgical valve, they align with the commissures. We are improving in transcatheter valves for doing that, but we are still there, and we have to consider commissure alignment and cell alignment, and we'll show in these examples. So we've been testing 3 configurations. Let's say that we have a degenerated 25 millimeter Navitor vision. So you see here that we implant with the markers. So this is the holder simulating the annulus, and you have the markers showing that above these markers you had 5 millimeter implant depth. And we're gonna put another Navitor inside and see what happens. So one of the key points, as I said, is valve expansion. So we're gonna try to see which sizing is the best. If we put a 27 into 25, what will it give us? 25 in 25, as well as 23 in 25. So just to make it sure that it's clear for everyone, if we put a tall in tall, like in this case, then the neoskirt will not vary according to the size of the valve that you put inside, because it's a tall in tall. So no leaflet overhang here, and the neoskirt will only vary according to the initial implant depth of the index valve. So if you implant at 5 millimeter depth, then you'll have an acceptable neoskirt, I think around 17 millimeter depth. But none of this configuration will change the neoskirt height. So let's start with the first configuration. So we're trying to put a 27 in a 25 millimeter valve. So we have Sadaf, who is a nurse, special for this case. No, so it's 27 and 25. Maybe we can zoom in a little bit. And you see that first we have the cells of the 2 valves that are not really aligned. Yeah. I think you can see that clearly. But before we think about coronary access, I just want to show you the expansion of the valve. So if we go in this side, you see that the 27 valve, and we measured that on the bench, is actually 23 in a 27, in a 25. So it's very underexpanded, and you can see clearly this in this example. And if I do that, you see that we have overlapping. I'm just going to take a little bit of...
Miriam, before you continue on this, if you do tall and tall like this, the risk is now the simulation you make is that these frames nicely align, but that's not always the case.
Exactly.
Yes, here above the nail skirt. So the risk you take, to my opinion, is if you do a tall frame and a tall frame, even if you have these very nice large cells from a navitor, you may risk, if you don't control this at all as an implanter, that you align these stent struts, that you make these nice big cells actually into small cells. Yes.
Yeah. And I think you're 100% right. And the key point is that you cannot predict that, and you cannot tailor that. You cannot predict how your cells are going to align. So we're going to try a catheter inside to see if that fits, if you can go through the cells. But just before we do that, I think you can see the pinwheeling, and it's the same on the slide. So you have a lot of redundant leaflet. So let's try the catheter, Sadaf.
Well, before we try, we actually try the catheter. One thing is important to stress, I guess. I mean, the presence, especially in this case, of the markers. These markers are fundamental to make sure that at least we have a chance, we have an option to correctly align these two prostheses. Because in other words, obviously, I mean, since the first procedure, we must be, and that's my opinion, be obsessed as much as possible with a correct alignment. But sometimes it's not really possible. But for the second, it's even more important that we correctly align the two valves. And the presence of these two markers must honestly consider as a good option to really do the job. Because now we are going to see in practice if it's really possible, even with these very large cells of the navitor. But you never know, because obviously if the cells are totally misaligned, you may be in trouble if you want to cross it. But just remember, we have ways to try at least to align the first valve as well as the second valve, especially in this case, if we use toe to toe. But please, go ahead.
Yeah, exactly. So I think you can zoom in just a little bit more. And so we totally misaligned the valve. So this is the worst case scenario, because of course, if they align, there's no problem, because we have large cells. So we totally misaligned, and you see that this is a 6 French catheter. And you see that it's kind of okay through the cells to go through. There's no bad issue. So you have enough space to put a catheter in. And, we can try all. So I've done the smaller cells, and it's pretty okay to put a catheter in.
Yeah, we can say that even if, let's say, you make a mistake, in this case, this procedure is kind of a forgiving one, because nevertheless, you made it misaligned, and you can blame your fellow if you want. But, I mean, at the end of the day, this is still possible. Oh, it's a good thing.
Sure. But maybe we could ask the opinion in the audience. Who has strong opinions? Who wants to say a word on this? Like, who, if they have to revalve a navitor, what would be your first choice here? Would you go for a tall frame? Would you go for a balloon expandable? Would you go for what's the factors you determine? You want to answer? Yes? Somebody? Yes? Please. Sigitas. What would you do? What's your concerns? What's your considerations here?
So first of all, probably I will try a balloon expandable valve. The most experience that we have or we hear from valve-in-valve procedures. Navitor probably would be my second choice, but definitely I would think about both of the options.
Yeah.
Okay. And which are the, let's say, factors that you include in your evaluation? Because obviously, if you go in a short to tall, okay, that makes sense.
Yeah.
But let's say, for example, that you have a relatively small anatomy again, so you don't really take the risk of a PPM at the end because you will have it. So, I mean, it's always a multifactorial evaluation, right? So, obviously, also the experience plays a role.
Gut feeling as well.
Yeah, that's right. That's right. But that's really an option again. It's something we need to consider, because typically when we started this experience with a redo-TAVI, we said, okay, tall and tall, bad idea. It's no longer the case. It's no longer the case, because you have this opportunity. And well, we have seen live that even if you make a mistake, you don't really care about alignment, you still have room for your coronary access. And honestly, we need to consider, this is not for very expert operators, we need to consider the fellow 3 a.m. in the morning, alone in the darkness, doing an ACS. And this is what matters. Because for me, for Ole, for all the guys here, whatever, it's not a problem. But you need to consider what is going to happen in a hospital in the countryside with a very small experience with this position. So remember, now we have the option. So we need to consider the options. And this is a good one. Please, go ahead.
And I think the option is also valuable, like if you have a very small annuli and you don't want to put a short frame balloon expandable valve, or if you have heavy calcium. If you have very heavy calcium and you don't want to put a balloon expandable valve, you know that it can be possible depending on patient anatomy. So I think we can move to the next slide and see the second configuration. If someone can...
Please.
Because this is all about revalving a navitor then in this particular case, but on the other hand, navitor can also be used to revalve other valves, yes? And maybe in a really good way even, because you... For example, you get really good hemodynamics. We know that from also in the surgical prosthesis that we get really good hemodynamics of this valve for using valve-in-valve, but TAV-in-SAV. This is now TAV-in-TAV. So definitely this platform can be used also for really revalving, first of all, surgical prosthesis in a good way, and also other types of TAVI platforms.
And this is so the 25 in 25 configuration. So we have just to remember that it's a pristine valve, so non-calcified valve. So 25 in 25 seems to be a good combination with not much under expansion, just a little bit, 23 millimeter for the redo valve. And you see that the leaflet come together pretty nicely. So we don't have this pinwheeling that we were seeing with the bigger size inside of 25. And if we think about coronary access, so this is an aortic root, simulated aortic root, and we put inside a 25 in 25, and you see that I misaligned the cells, and you see the same that you can, reach pretty easily the coronary ostium in this situation, although it's a smaller valve combination, and you still have a misalignment.
Of course, also Miriam here in this is purely bench test, of course. So you say there's no pinwheeling. I'm sure if it's implanted in a real anatomy, calcified anatomy, you have to be careful with your sizing there. I think that's also the message. If you have to do TAV-in-TAV, I think it's not necessarily, if you would talk about now navitor and navitor, you necessarily have to take exactly the same size as a first implant. You really have to do still a good CT analysis. Also, another question which is not answered is the pinwheeling is really an issue for every valve, because this particular valve has really nice long leaflet coaptation.
Yeah.
So maybe it is for this particular valve less of an issue. If you have under expansion, I mean, there are some data that it performs well in really elliptical. I don't know if there's data on even under expanded scenarios, but it seems that this valve comes away with a lot from ellipticity for sure, so maybe also under expansion.
Probably we'll need to have more follow-up for that, clinical follow-up to make sure of this, but yeah, probably we have still a lot to learn about this. So you see that the catheter comes nicely through, so no major pinwheeling, and yet we're not sure about the impact of long-term of a small pinwheeling and accessible coronaries.
So Luca, should we move further to to the recorded case from Rafa maybe? Because thank you, Miriam, and maybe a comment.
Pinwheeling with this navitor in navitor rather than a balloon expandable?
So it's difficult to really address this question because it's difficult to compare the degree of pinwheeling, but it will depend on the implant height of the sapien in navitor. So we still have a lot to learn and we're still running tests, so I can't really give you a clear answer, but the less the valve is underexpanded, so the more it's expanded, the less pinwheeling you're going to have. So we really want to have less underexpansion as much as we can.
The question is the overhang of the leaflets. This is more likely to happen with the balloon expandable valve, right?
Yeah, exactly. A short frame in a tall frame valve, this is where you're going to have leaflet overhang.
Yeah, you will never have this tall and tall, you will never have overhanging leaflets. Yeah, indeed. So, for the sake of time, I think maybe Luca, you can give the introduction for the...
Yes. Well, actually, now we move to the other side of the spectrum because we started talking about a small annulus, small anatomy, and all the problems related to that. But then we move to the other side. Of course, as well, this is a matter of concern because the very large anatomies are still in 2024 a matter of concern because in terms of, let's say, technicalities, the procedure is a bit more, let's say, tricky, but also there is not a lot of options. But nowadays, we have an additional one. And then we are going to see a case where the new, let's say, added option is there. So please, Rafael. Show us.
So let's cut to the case.
Maybe before you continue, this is actually news. Yes, this is new. First of all, the Navitor. Most of you knew already, maybe from last year's session here. But now they have the Navitor Vision. So you will see during the case they have these markers corresponding to the commissures and giving you some depth and also helping you in the parallax assessment during your implant. And then the 35 millimeter. Yes, that's what you're going to show. Yes, Rafa.
Yes.
That's also brand new on the.
Let's present the case quickly. So this is a 79-year-old chap with breathlessness angina on exertion with previous coronary bypass grafting, history of stroke, diabetes, hypertension. So his ECG shows sinus rhythm with no PR interval, no accurate duration, and moving, and the echo, which is coming now, and the echo show obviously severe aortic stenosis with mild paravalvulic, mild MR, and no doubt there's kind of severe S with mild impaired ventricle. So here the coronary angiogram before as part of the planning for the procedure because of the previous graft surgery. Sorry for this. Avoid this. That's it, it's playing. So it showed patent graft, so patent graft to obtuse marginal, RCA, and Lima LAD. And obviously routine CT, which showed a large aortic annulus with minimal dimension 26, as you can see here, and maximal dimension 30, with perimeter-derived aortic annulus around 28, with area of 620. The valve was symmetrically calcified with calcium score over 3,000, with tricuspid anatomy, so no much of a concern, but this kind of mild LVOT calcium.
Yeah, well, I was about to say, I mean, this is, let's say, tricuspid configuration, a lot of calcium, but that's aortic stenosis, so we are ready for that. But if you look at the numbers, which makes a difference, perimeter, 88.7, but also a very large area, obviously. So even now in 2024, we don't have a lot of options. And then I have to say that this new size chart from Abbott is honestly very interesting because it may cover something that was not covered before. And as you can see here, you have I would say, extra large anatomy. And the extra large anatomy is always a matter of concern, especially for the residual paravalvular leak maybe, but also for the stability of the procedure. So I have to say that the presence, and Rafael will show that, the presence of the markers, but also the increased stability of the delivery system altogether is honestly a very good option to consider obviously. It's not just that the valve will be placed easily. No, it is still a procedure you have to do. But definitely, if you have more options, and you have it now, you can also do a good job because you can size, because you can align, because you have, let's say, decent, reasonable chances to have a very nice relief of the paravalvular leak. And also, in terms of techniques, we'll discuss that later on, you can minimize also the risk of pacemaker implantation. But please, Rafa, go ahead.
That's very important points you made, actually, because when you plan the TAVI procedure, it's important to avoid paravalvular leak, avoid pacemaker, and that's important for the lifelong valve, essentially, and for revalving as well. Access is not controversial in this case, and routinely for planning the procedure, we get the overlap view and tricuspid view, which is very important, and it's part of the technique when we want to achieve accurate depth of the implant. And as I said before, it's the essential part of the procedure. So essentially, we have symptomatic patient with severe aortic stenosis, with logistic Euroscore 4.6, STX score 3.6, with feasible transfemoral access and aortic anatomy. You may say mildly unfavorable because of LVOT calcium with large anatomy. may not have much of a concern, but there is alveolar calcification, so you may have a high risk of pacemaker with bigger device, I think.
Yeah.
I don't know if you want to discuss kind of any option how to treat this, but I think in the current era, probably is no doubt that TAVI will be the first.
Is there anyone thinking that this is not good candidate for TAVR? I think it is. I mean, obviously, if you look at the numbers, low intermediate risk, but we have mandate to treat these patients because we know the results are very good. But honestly, I say mildly unfavorable because of the calcium. That's questionable, of course, because this is the disease we are treating. So I think there is a good option, especially having the right tools. So unless there is a different opinion, just looking around, apparently we are all okay. It's all set, so we can proceed.
So we can proceed. So the planning is to do the 35 millimeter Navitor valve with FlexNav system through the right femoral approach with predilatation with 26 millimeter balloon. We could discuss the predilatation when I show the case.
Would you, indeed, I was about to ask. I mean, predilatation, there is always a debate in predilatation. There are also, as you will know, there are some recommendations coming from the company, which obviously is the case. But, I mean, when you size the balloon for predilatation, tell us how to.
I think it changed, I think. Initially, I was using the minimal dimensions, and now I'm moving more towards kind of medium, mean dimension. But everything depends on anatomy, I think. So if you have an oval annulus with no alveolar calcium, I'm being braver with how aggressive I'm predilating. If it's elliptical annulus with calcium on the short ends of annulus, then maybe you have to be more careful because you're risking annular rupture.
Okay. Is there any specific rule for predilatation that you are following? Any idea? Any approach? Sorry? Again.
If it is elliptical with calcification, as he's saying, I would go for the shorter diameter. And if it is better, more oval, then I would take a bigger balloon.
Okay. Okay, but if you just say, okay, these are the numbers, okay, I have 22 minimum and 29 maximum. So the average is around 24. So what do you want to do?
That is very extreme, 20 and 29.
That's why I said.
Yes. Yeah, probably if the calcium is not too bad, I would go for like 24. But if it's, as we in India find a lot of bicuspid valves, and if it is very adversely calcified, I would be conservative.
Okay, so let me just focus on one little information. We need to remember that this predilatation is not meant to relieve the aortic stenosis. It's just meant to facilitate the crossing, facilitate the procedure. Also, you need to remember, with this specific prosthesis, you will never see a significant drop in the pressure. That's a big point, because we are all used to see that the pressure will just go down a lot during the early phase of the deployment. This is not the case. So in other words, remember, either you use the minimal, either you use something bigger in terms of predilatation. Just remember, the hemodynamic will be pretty much stable, okay, during the early phase of the implantation. So, I mean, depending on what is your practice, but also the availability of the balloons, because I've been traveling around, and honestly, I always ask for a 23, there's no 23, so you have to use 24 and then 22. So that's real life, okay? But show us what you've done in real life.
Good, so I could move on. So again, for me, the TAVI as well is about optimizing the procedure and being minimally invasive. So as when I move to ovular view, so to start the procedure, so this is our autogram of the ovular view, and I try to cross the valve with ovular view as well, just because, as we know from the CT, this corresponds to three-chamber view. So actually, you don't have to change the views when you cross the valve. You can place the pictal in the apex, and it's in controlled way. So that's what we've done here. So crossing the valve and then predilatation with 26 balloon. But before predilate, because the Titan is a big device, so we want to make sure that the valve is connected properly. So all the retainer tabs and the valve it's within the system safely. Connected, because we don't want to do balloon valvuloplasty, have severe AR, and the valve not being ready to be used. So this was the screening and rotating the device during the screening to make sure that the valve is not distorted. So balloon valvuloplasty you've seen before was effective, one inflation, rapid pacing. as you see, this delivery system is the same delivery system as 29mm delivery system, and it travels very easily across the aortic arch with no issues, no resistance. It actually behaves very similarly to 29mm device, so I didn't feel any difference. This was my 835 valve, actually, and in none of them I have any problems with delivery. Again, overlap valve view, so isolating non-coronary cusp, so very important that the pigtail sits at the bottom of the non-coronary cusp, so we just confirm that this is in the right position. And then
Rafael, just sorry to interrupt you, but I just want to ask one little thing, which is really important. So what is the first implantation view that you use? The first one.
Overlap view in isolating non-coronary cusp.
Okay, okay. Anyone else? Different ideas? Cusp overlap, coplanar view? I mean, there's always a lot of debate around it. And there are also, again, some recommendations. But I start with this, and I always start with cusp overlap, and then I use all of them just to check it. Anybody else? Different options, different ideas?
Well, maybe one other question also to the audience. Now you're working in the strict cusp overlap, right-left cusp overlap or NCC isolation view. That's good. But you see already immediately on your markers, you have some parallax, yes? So who would stay in this projection and continue as it is in this projection, or who would try to kind of compensate and take out that parallax by probably going a little bit more caudal, or if you can't go more caudal, take a little bit of REO away? Who would take away the parallax already in this stage? Who would do that? Very few, a minority.
Very few.
Yeah. Okay, that's surprising to me, I think. Okay, let's see what happens further.
Okay, yeah, let's see what you've done.
So again, I'm aiming what I learned with Titan, that I have to start a bit deeper because I like high deployment. So normally I'm for 3mm implant with all other valves. But because the anatomy is so big.
Okay, now you change angle also.
Yeah,
yes.
You correct it.
So you correct for the parallax. Yeah.
No, but now I'm moving to LAO view. So I'm starting in REO, I'm confirming the depth, start opening the valve. When the valve is not moving, then I move to LAO view.
You went already to LAO.
To assess, and in LAO view, I remove parallax and looking only in the plane of navitor. So I'm not looking at the kind of the view given.
What was your reason to go already to LAO before having already some kind of decent expansion of your valve?
So the reason I moved to LAO is to align the system, so to be with the system in the middle of the aorta. So don't having hugging on the kind of external part of the aorta or internal part of the aorta. So just to be in the middle, essentially.
Okay.
And this is just to get the plane of the valve within the plane of annulus.
So how do you do that? So by manipulating the wire?
Yes.
Yeah.
So either by pulling on the wire, pushing on the wire, and if you actually, because the valve is sitting between the non-right coronary cusp, so actually the valve could be pivoting within this point. So when you push on the device or pull on the device gently as well, this will change the angulation of the plane of the valve in relation to annulus.
So now you end up probably, if I may say, probably it's too high, yes?
Yes, I'm kind of.
So that could be a result of starting out in your strict cusp overlaps, holding to that and positioning your valve there without taking out the parallax, I think, because you don't know actually how your valve also opened up with a lot of parallax there. So that could be something to consider, to take already initially in the early phase of your opening, before the valve really actually opens, to try to go to a view. You stay as close as possible to that cusp overlap, but you kind of try to take out that parallax, yes?
And this is an excellent point, because you will see it here now.
Yeah.
With a kind of one more recapture when I remove the parallax.
Yeah.
Because I was worried that actually that's in this view, you will see now it's open in our caudal view. The valve will be looking fine, but still be not looking fine in LAO view. It's always higher in LAO view. So I did open up the valve and then move to LAO to remove the parallax.
Mm-hmm.
Yeah. Let me just make a brief comment about it. I mean, as you can see there are 4 dots. For those who are not pretty much familiar with this new device, with this new addition, just remember there is 1 dot, 1 marker on the delivery system. You should not be looking at that. You got 3 markers exactly underneath the commissures. And that's why Rafael was actually able to correct the parallax, but also to follow the anatomy. So look at the delivery system. There is a dot. Don't look at that. Okay? You got the 3 markers just underneath the commissures. And these are the 3 markers you need to take into account. But please, Rafael.
So I stop here because actually this still I try to adjust, but it was still the valve was a bit too high, I thought. So in this, actually, the next shot will probably prove the point why the removing parallax is so important. This is the areocaudal view from the CT. And you see the valve is not aligned very well. So I'm now trying to, and I'm always in LAO finishing much higher than I think I am. So I'm now removing parallax and changing the angles. And you understand now why in LAO the valve looks much higher, because
yes, because your valve is canted.
Exactly. And you see actually the pigtail in this view looks like it's above the valve, but if you remove the parallax from the valve, it just sits at 0.
The good thing is you can see on the hemodynamics, this patient stays all the time hemodynamically stable. So that's a nice feature, I would say, of having these very early functioning leaflets. So there's no need. You can use pacing, but it's up to you. I mean, you can either use pacing or not. This valve can let itself implant with or without pacing. And normally the hemodynamic stays very stable also with repositioning. So that's a nice feature for sure about this.
And this is the removed parallax view. So I move more caudal to be aligned with the plane of the valve, and you see actually that we're 0. And this explains why in LAO view we're always looking like we're above the valve.
Yeah, so you just aligned the points, and then you see that you're too high. You didn't move the position at all.
Exactly.
And it's pretty impressive, because on the previous position, when you have parallax, you think it's okay.
Yeah, exactly. Yeah. So and then you work with this view. So what I did now, knowing that this is my kind of view I want to work in, I recaptured the valve quickly, let it drop by 1 mil, and then open up, pushing on the wire. And if you look at the wire, you see what I was doing. I was pushing on the wire to lift the left aspect of the valve higher. And that's what happened here. So the valve expanded more. You see, valve is more expanded. It's bigger, much bigger frame, much freer frame than before. And I quickly moved to LAO, just sweep the C-arm to LAO, just be sure that I'm pushing on the wire and making sure that I align within the annular plane, just to make sure that the left side is not too low. Because if you do this maneuver, you may finish with left side being too deep. And then you have an AR on the left side.
That's a key point here, what you say. I mean, if you want to check on your left side, yes, your LCC side, how deep you really are, it's mandatory to go to an LAO. Yeah. You can even go, you can call it like a right non-cusp overlap view. You know, you can see up front on your CT how you overlap these right and non-cusps the best, and you isolate the LCC the best. You can go to that particular degree of LAO. That's what I do. And then you're really sure you don't miss there on that left side, on the left main side, that you don't miss there, that you're maybe just only at 0. That you make sure you're there at minimum at, or you aim for 2 millimeter actually. That's what you aim for.
And this is absolutely important, but let me just a little add on. And those three, the line that is actually connecting these 3 dots, at least in theory, should be placed at the level of the vitreal basal ring, just to ensure the correct placement, the correct depth, which is around 3 to 4 millimeters. And this has been associated with a minimized risk of pacemaker implantation. So not just the alignment, but also the depth of the implantation.
And how do you know it's the depth? Maybe you can comment on, Rafa, on the markers. What is the indicators? What the markers are? What depth are they?
So obviously the marker are kind of if you look for the bottom of the marker to the bottom of the frame, is 3 millimeters. Mm-hmm. Above the marker is 5 millimeters.
Yeah, 4.5.
Kind of, I'm finished here roughly around 4 millimeters, I think, on the non-coronary cusp. Maybe 1 millimeter more on the left. But the skirt height here is 11 millimeters, I think, for 35 Navito.
And
so it's
your delivery system is pretty nice in the center of the aorta. You also look to that. I do agree that it's important with any platform, by the way, before you then really release this. So.
Yeah, being orthogonal, meaning that you have to place your delivery system ideally at 90 degrees to the vitreal basal ring. So in other words, it has to be this position, this configuration, which is pretty good.
So we did the echo. You've seen it before. There was no gradients, no AR, kind of trace AR, let's say. And I normally take the pigtail out for final release. Pull on the wire, so release the tension from the system, so there's no tension in the system. And you can appreciate as well here now with this kind of releasing recording, we release the valve. The valve is expanded much nicer than the first few opening. The valve was constrained.
Would you suggest to pace during this phase?
I'm not pacing during release. I paced only 35s when the valve is moving, but normally I don't pace navigator valves when I deploy.
It's not mandatory, but it's clearly something that you need to think about when you have some kind of unstable delivery or release of the valve. But again, it's not mandatory. No, I would not even say recommended, but it's a good idea sometimes.
Can't you reduce the stroke volume by pacing? And once the valve is only partially unsheathed, then with a big stroke of blood, it could really push it up.
Exactly.
I want to avoid that.
Exactly. So that's the final result, I guess.
And the pullback, there's no gradients, no. This is final result on the echo. Actually, I did the echo before you've seen. I did the echo at 80% of before release, because actually I found it as a good indicator of final result. So if you're at 80%, you don't have an AR on the echo, then this means that you definitely will not have an AR at the end. Yeah. If you have, but sometimes if it's more challenging anatomy, LVOT calcium, that's very helpful actually.
You don't have drop of pressure, so you can take time to do that. And
exactly.
All right, this was a fantastic demonstration of the opportunity that we have nowadays. For the sake of time, I give the speech to Ole, just to close up.
Yes, I just was also informed we come to the end of the session. I hope this session was really interesting for you to see, first of all, the Navitor platform, to discuss a couple of topics, lifetime management of when we have to treat patients with a longer life expectancy. So as some key learnings, planning. For sure, if you do TAVI, your planning almost is as important as the procedure itself. So planning is key for success, whatever you do. And the Navitor Vision platform offers the opportunity to optimize acute as well as long-term outcomes for our patients. I hope we also could show on that. And then know your device. I mean, know your device, whatever anatomy you have to treat, small, large. Now you have the option with the Navitor to treat also the large anatomies with the 35 millimeter. They also give great performance in small annuli. PVL prevention is important. Refined implantation technique. We discussed a lot about the implantation technique on Rafa's case. Performance with hostile access. I think also here that was not discussed in this session, but the deliverability of this platform is really good. I mean, it tracks really good. The deliverability and the flexibility is high with the FlexNav. Hemodynamics, coronary access, and the redo-TAVI options for the future options of our patients. So with that, I would like to conclude this session. I hope it was interesting for you, and I have a good finish of this PCR London valve still. Yes.